Oh, good. Welcome to our leadership team from Northern and Southern California, including many of the major health systems across the state. And thank you for all of our partners who have made this collaborative so vibrant. And it's just a delight to see each other and be able to be a support system to one another in these times of needing to stay calm in a crisis. And together we can do better. Next slide, please. And so Richard Figueroa and I have worked together, believe it or not. Richard, I think the first time I met you was in 1996 when you called me to ask about, to brainstorm about risk adjustment. And that started a wonderful friendship. And Richard, for those of you who don't know him, has been at the center, he has been the calm at the center of the storm in health policy in the California state capitol, really for well over 2 decades, really 3 decades. As several of our leaders said before we got started, transparency is really important, and Richard has been wonderful about helping us to have transparent, solid metrics in the world, in other worlds that we've worked in together, in health reform, in quality improvement. He has an MBA from UCLA, undergraduate UC Davis, and he is brilliant, and we're very lucky to have him sitting there in the governor's office in what we call the horseshoe, helping us all to get through this. So with that, let's go to Richard's first slide. And thank you, Richard, for being with us.
Sure. Thank you very much, Hattie, for that overly generous introduction. So again, Richard Figueroa, I'm a Deputy Cabinet Secretary here in the Governor's Office. I work on health and human services issues. I really only had one slide, but just before we kind of get to that, I typically do this. I have done it before in January when the budget comes out. I think when we last put the budget to bed in June for July, things were looking very, very, very dire in terms of our budget. We had no idea kind of how long the economic downturn, which has been very severe in California, in terms of the level of unemployment, et cetera, and people in distress, would really be. Interestingly enough, our budget hit wasn't anywhere near as hard and deep as it was going to be, and so a lot of the cuts and things like that, and lack of resources or tightness of resources we thought we were going to have, has thankfully not been as dire as we thought. It does, I would note, point to the huge income disparity in California, because a lot of the impact of COVID has been felt at persons with lower socioeconomic status versus the higher net wealth individuals that generate so much of our tax revenue. So even though we are very pleased that we have additional resources, much more than we would have expected, it does still call into stark detail a lot of the disparities that exist in society at the same time. So just generally, again, during these difficult moments for California and our nation, the state is advancing a budget that funds COVID response and relief efforts where Californians need it most. It also reflects a sustained commitment to the families and businesses hit hardest by the pandemic. So what I thought I would do is just kind of go through, this is a page from page 46, actually, the governor's 8 pages. And the governor's 8 pages is the thin book that is online associated with the governor's budget there. That can be found at the Department of Finance website. So if any of you want to see this later, you can go there. There's actually a much more detailed description of all this, but I thought I'd just kind of give you a general overview of kind of where we are and where we've been. So when we did the budget last year, and the document you have in front of you, the page, kind of breaks up our expenditures in a number of key areas that, in terms of the way that even the governor talks about it. Many of you have probably seen his his PowerPoint presentations at noon, et cetera. And so this is the kind of the way that we look and depict what we're doing in California. It involves things like state operations, procurements, hospital and medical surge, hotels for home care workers, housing for the harvest, which relates to ag workers, vulnerable populations and other support. You have things like for the homeless, food banks, things like that, statewide testing, contact tracing, vaccine task force, other response costs, and community engagement, which is now gearing up. So overall, it's about, when we started this in June and July, trying to put the budget together, we thought we'd spend about 8.6 billion. We're obviously well north of that, almost 13 billion dollars. It's important also to note that only about 2.5 billion is actually state funds at the moment. The federal government in many categories provides 75-25, to 75% federal funding participation, us 25%. So a lot of the dollars here are really at the end of the day going to be federal dollars. Just more specifically, just kind of going through this, as you know, we obviously are doing lots of testing in state-run facilities, whether it be our state hospital system for those persons with behavioral health issues, or our hospitals in the correctional environment. There's obviously National Guard costs, and many of you know, National Guard has been deployed in all kinds of environments here, including medical surge, food banks, all kinds of stuff. Under correction and rehabilitation, you see, obviously you all knew about the big outbreak at San Quentin and the issues that we know how rapidly it spread through San Quentin. That's obviously been the case in many of our other facilities as well, and it's led to very large costs in terms of staffing and testing and everything else. Procurements, many of you have maybe on this call been recipients of some of the very large scale procurements that we've done in California through BYD and others. And again, that's an ongoing, whether it's, more recent shortages in gowns or gloves or whatever it is, that operation kind of continues moving forward. Hospital and medical surge costs. We're obviously in the middle of a big medical surge right now and standing up these alternative care sites, paying for the thousands of staff that we are paying for to help staff those surge sites comes out of this, as well as supporting hospitals in their day-to-day activities. Hotels for healthcare workers. We've had, my gosh, must be 100,000 days worth of hotels for hotel workers who are because they're either sick or have to quarantine or are afraid to go home because of their behavioral exposure. They're able to do it that way. Housing for the harvest is related to agricultural workers who might be in quarantine or might need to quarantine to stay away from their family and still work. Then there's vulnerable populations, Project Room Key, that's for the homeless. We've brought additional resources to food banks, additional resources for small business, et cetera. On the testing side, I think many of you are familiar with the new lab in Valencia that the state has stood up to increase our testing capacity by 150,000 tests a day. And then maybe, the other big cost is just OptumServe and Verily, which were the first fixed sites in California that continue today to provide testing resources all over the state. And then contact tracing, vaccine task force, and other kinds of things. Because again, overall, it's a very, very large response. And again, in kind of detailed measure there. So just kind of where we are in the trajectory of this thing. Obviously we've had several surges now. We never got the level low enough in terms of the baseline or underlying rate of transmission to not be building on every other surge. So every time we have a surge, we're starting at a higher level, which puts more and more pressure on the hospitals as we go through. We are still seeing the post-Thanksgiving surge and then maybe now the post-holiday surge. I don't know that we know right yet exactly when, if we're at the height of the surge on the surge on the surge, or if that is still coming. As folks on this call know, hospitalizations are kind of a lagging indicator. Obviously, you have a ton of folks identified first, they're tested positive, and then 2-3 weeks down the road, you have a higher rate of hospitalizations, and then eventually a higher rate of fatality that lags that. So we're watching the numbers very, very closely. As you all know, we've had to institute a number of additional stay-at-home orders to kind of try to reduce the pressure on the hospitals. We've stood up alternative care sites all over the state. So I expect that we will know, hopefully in the next week, kind of, in terms of like where our testing or where our positivity rate is, to kind of see where we are post-holiday. I think we need a little more data to see where we are post-holiday. And then obviously from there, we can make more projections based on that we know about 12% of the folks that are tested eventually end up in the hospital. So we've been that's the rough, back of the envelope number that we've been using. And so depending on kind of where testing goes and positivity, you kind of have work through some general metrics to figure out what hospitalization looks like down the road. And then of course you kind of are always testing that against, real numbers as you go through. So, we will know within the next week or so, I think kind of where that post hospitalization positivity rate is, which eventually, of course, translates into hospitalizations down the road. Obviously, the other big story is around a vaccine and the availability of vaccine. And I like everybody else has seen the recent articles about the generally slow uptake across the country. California is in the same place. I would note that the way that the numbers work nationally is that we get our allocations on a Monday. Entities order by a Friday for the delivery the next week. And so all those allocation numbers are always at least a week, if not more, ahead of actual shipments or delivery to California. So you're always going to see a higher allocation number than you will have an ordered number, then you will have a delivered number, then you will have an administered number. So there's multiple steps along this chain that kind of affect the numbers and how you might calculate things. The governor last week announced that he was undertaking a campaign to get 1 million shots in arms over the next 10 days. And so we have been pushing very hard among all the entities that are administering vaccines to figure out who has additional stores that they could either use themselves to deploy, give to others, or open up their doors more broadly to a larger segment of the community to get that done. We have a distribution system in California where a little bit goes to the state for state populations. A portion of it goes directly to CVS and Walgreens off the top. The federal government pulls vaccine right off the top and sends it to CVS and Walgreens to provide in-facility vaccines to nursing homes and all assisted living, RCFEs, et cetera, except for LA County, which is doing its own. So the rest of the state is getting a direct in-facility vaccine. Those numbers also lag. The numbers are pulled way off the top at the beginning, sent into storage, so they make sure they have enough to send out to Walgreens and CVS to do that. And then the biggest chunk goes to counties, who then have their own distribution systems and are kind of each doing, you've seen one county. And then another chunk, but a smaller chunk, goes to what we call multi-county entities. These are typically large systems, large hospital systems, Kaiser, Dignity, formerly known as Dignity, or a few Sutter, a few of the other big ones get their direct share as well to redistribute to all of their facilities to make sure the healthcare workers are done. The other thing I would say is that besides the million challenge, the million vaccine challenge in the arms to kind of catch us back up quite a bit, the governor on Thursday also indicated that the current priority / tier system that we have in place, there is some perception, either the provider and or the hospital level, that there isn't as much flexibility as there should be within that to move vaccine quicker. And so the governor made it very clear that folks that are receiving vaccine should make it available to everybody in all 3 tiers of phase 1A, which is basically all the healthcare workers. Try to get all the healthcare workers in. And if you're ready, go to phase 1B tier 1, which I know that Dr. Brooks will be talking about a little bit later. But if you're ready to move on to phase 1B, move on to phase 1B. And phase 1B has individuals 75 plus, as well as some employment sectors like teachers, emergency workers, food and ag, workers, that kind of thing. So and again, to try to make it very, very clear that that's the case. So that means that, we've also been very, nervous about, and this is probably adds to some of this too, about, we don't want individuals taking advantage of this in order to monetize the vaccine, which of course is provided for free. We don't want people monetizing it in an inappropriate way, so that people that have resources get it before other people through paying them or things like that. So we have been pretty clear about on the enforcement side going after folks that do seek to monetize it. And otherwise, we don't really want people skipping ahead too far ahead of the line. At the same time, we want to make sure that providers and counties understand that we also don't want vaccine to go to waste. And we know in some, we know that with at least one of the vaccines, because it requires certain, has ultra low temperature requirements and things like that, there are more challenges with one than the other. There's also more challenges with one than the other in terms of the amount. It has to be shipped at one time. And so there are some things that are kind of playing into this that have made it a little bit more difficult to get this out as quickly as we wanted to. So we're trying to, take steps, within the last few days to really make sure that providers and local health jurisdictions understand they have more flexibility, or clarify they have this additional flexibility, even though we think it's been kind of clear, but to make it super clear that they do have this flexibility to kind of move, and so we can kind of move faster. I would just say in the longer term, we will have a new administration within, I don't know, was it 10 or 12 days now, whatever it is. And we have every indication from public press reports that they will likely have a different approach in some sense to the current administration. And so at the same time, we are working on trying to move quickly to get the vaccine that we do have in-house out. It could very well be, again, don't know, but from everything we've read, it could very well be that we need to prepare for a much larger bolus moving through the system coming to California. And so right now we are, taking the steps to work through what that looks like to get a lot more out a lot quicker, given that we may have a lot more than we even have right now to move through the system, which of course is that light at the end, that proverbial light at the end of the tunnel. And the quicker we can get through that, the better it is for the entire healthcare system, and obviously our whole economic system, all of California generally, the schools, et cetera. So I'll shut up. I tried to cover as much ground as I could. I cheated a little bit. Some of the folks on this call, because I was on just a little bit early, gave me some of these questions to kind of tee up so I could try to answer them as I go through and hopefully answer some of the pressing stuff. The other big question was about transparency. We are working on a dashboard at the statewide level so that you can see at the statewide level kind of what's going on. It is very complicated for the reasons I indicated between the word allocation to the gets in the shots and arms. There's different points of contact in there. There are also different systems, some of which are federal that we don't have as much visibility in, that make this a little bit challenging too. But I do think relatively soon here, you're going to see kind of some changes in terms of the statewide visibility, as well as additional assistance for counties on the technical side to try to provide more visibility in terms of how do people know when it's time, what's the appointment, help with appointment systems, things like that. So we're taking a number of steps right now to try to get more of this stuff in place, not only for the current vaccine that we have, but what we expect to be a big push in the future. Hattie, maybe just a question or two, and I know Dr. Brooks, who's been so gracious for allowing a lot of his time, as busy as he is, to assist the state, particularly on the vaccine side and working with our Community Vaccine Advisory Committee, all the many hours. And I just want to give you a big shout out, Dr. Brooks, for co-chairing. One of the committees that's helping us kind of get through this. We're lucky to have so many excellent people in California that are either working on the vaccine review process and helping us draft guidelines and just everything. We're just so lucky to have so many academic and other centers available to us. So Hattie, one or two real quick, and then I'll shut up.
Why don't we hear from Dr. Balmer, since he's our chairman,
Yes.
and he's very involved with the American College of Cardiology and all of the UC cardiology across the state. And as we know, the impacts on the heart and the cardiovascular patients are quite concerning. Go ahead, Dr. Balmer, you're muted.
Well, thank you very much for that presentation, and we certainly appreciate all that you do and what the state does and all the people that are working hard on this pandemic and our response to it. I think we were talking a little bit earlier about we're just able to accommodate the current surge, and we're surviving, although not happy, and hopefully we'd love to see a little more light at the end of the tunnel. And one of the questions we talked about earlier was the two things was, should we unleash more of this or be more flexible in our allocation of it or allowing people to be received? And the other is the state of California saving any second doses at this time, or is that all done nationally?
We're not saving any second doses. That's all done nationally. So when the way this works is the feds are keeping track of who went through their system to get a first dose, and we got 326,000 or whatever in the first week, and so they were holding back 326,000 to resend to those same people who ordered the first dose, kind of thing. And then the providers have to go back into the federal system and say, I want them now, and then they get shipped from the feds. So that's kind of how that is working. And there's this whole separate conversation going around about, should you be can you put off the second dose so we can get more first dose out there? I'm not getting into that, but it is a federal system. They were holding back vaccine for that second dose to make sure that it went out when the providers went back in there and ordered it. To the guidelines question, I mean, it could very well be, again, I'm not, Dr. Brooks has been chairing that work and can speak to this in detail when he makes his presentation about the different trade-offs that were involved in setting up this phase and tier system. And so I would certainly defer to the good doctor and all of his work in this. But it could very well be that as a lot more becomes available, we have to adjust to the whole system. Some states are already moving to kind of more of an age-based, somewhat more age-based system than an occupational risk system. And so, again, I think we'll be working in concert with the drafting guidelines work group as they advise us on these things. But again, things could really change a lot if we have a lot more vaccine. And I would just note, and again, this is Dr. Brooks's world, but I would just note that even in some of these phases, some of them have 6 or 8 million people in them. I mean, we're just a huge state. And so even some of these phases just have millions and millions of people in them. So it's going to take quite a while, no matter what we do, to kind of work through this. I think the other thing that we didn't expect or didn't know going into this, which has led to some of these issues, is, it's taken a while for, I think, all of our systems to figure out what our turn down rate's going to be, what our refusal rate, what our declination rate is going to be. And so I think there's a lot more out there than maybe even the systems might have expected based on declination rates. And that's a matter of communication and things that we know we have to do better on to educate the public about the importance of the vaccine and safety. So we can get those rates up a little bit closer to what we expected and get more folks. So, again, there might be a little bit of mismatch right now because of declination rates and others about where the vaccine is or where it needs to go. That's another area that we kind of need to work through, even with healthcare workers. In some areas, there's been a pretty sizable declination rate when you wouldn't think there would be necessarily. But again, there's a lot of vaccine skeptics or a lot of skepticism around either the EUA process or was it rushed or things like that. So again, I'll leave that to Dr. Brooks and all you august folks on the call about that.
So Richard, I just want to say that among our leadership with us right now, we have 135 people signed on, and only our leadership has their videos going right now. But I think I can speak for all of us in saying that, across the various academic institutions that we have present with us from our leadership right now and major health systems, we are all available to assist. And I think keeping the dialogue going is really important because I realize there's just such pent up demand to actually speak with you to, and I think maybe we could arrange that when you're not double tasking with the governor asking you to be at a press conference with him right now. But I want you to know that we have two of the major pharmacy leaders on the video with us, Steve Chen from USC and Cindy Jambroni from Memorial Care Health System, along with Keith Emmons from CenCal in Santa Barbara, Oliver Brooks, Watts Healthcare, UCLA, Stanford, UC Davis, more from Berkeley, et cetera. So if you feel like signing back in later, I have a feeling that this discussion is going to go, very long because.
And I know some of them. I saw someone shaking their head to some of the things I said, so hopefully I wasn't too off base here. I just want to give you an update of where we are. And I really do got to run on to this other.
I want to say real quickly, what he's talking about is incredibly complex, and we really appreciate the work that's been happening at the state level. And I, for one, am proud of Richard, the work he's doing, and what our governor and government is doing. So I just think it's important for people to know that this came out of nowhere, and we have responded, and he's part of the response. And I think that should be noted.
I'd just like to thank Richard also down from UCLA, but I just hope the governor's legacy, we've had the Terminator, we need the vaccinator. So I'm hoping the governor's legacy is helping us down here. I'm in the ICU for the next 4 weeks, and we need vaccines to long-term care facilities a month ago.
Thank you.
Thank you.
Thank you. And Liz Helms, you sent me 3 questions. You know how to get a hold of me offline. So we'll call me Liz. Thank you, folks. Thank you. And thank you for all the work you're doing. You guys are all on the front lines and helping us, keeping things together the best we can here. And it's been a Herculean effort. And I know that, we all will be able to hopefully look back at this when we get some sleep in a few months here. So thank you, folks.
So we have these sessions about every 2 weeks. Richard, as often as you want to join us, we'd love to have you with us.
Right, thank you. Thank you, folks.
Thank you. Take care.
Bye.
And with that, I'm going to hand it over to Dr. Balmer to do our next introductions. Thank you to our leadership team. I see Dr. Balmer's video seems to be off. So Dr. Balmer, can you chime in, please?
Yes, I can. I turned off the video so that I could focus on our next speaker, Oliver Brooks, and we're delighted today to have Oliver here. Oliver is a part of Care and is actually a co-chair. He is also the immediate past president of the National Medical Association and is currently chief medical officer and chief of pediatric and adolescent medicine at Watts Healthcare Corporation in California, and director of the LA Care Healthcare Plan, which is one of the nation's largest Medicaid managed care plans. So as we heard earlier, Oliver is also a co-chair for the state for the COVID response. And so he's going to detail today some of the efforts of the committee to develop a program to actually figure out the best or most efficient, equitable way to distribute what looks like the only window at the end of our tunnel, which is probably the vaccination program. So we're delighted to have Oliver here today in his busy career, and he is both boots on the ground, taking care of patients, as well as running committees. And so, Oliver, thank you for joining us today, especially at what I hope is the peak of the pandemic, and hopefully it starts to go down beginning tomorrow, based on your talk. So Oliver, thank you very much for joining us.
All right, thank you. So I need to, there you go. Let me do this. All right, so I am now in share screen. Okay, good. So let me go back. So Okay, let's just start. So this is my my presentation. Here we go. So let me do this. Okay, so can you guys see that now?
Yes.
Okay, good. Got you. So thank you for having me here. I have no conflicts. And so what I want to do is I'm going to present kind of just a little bit of background on how we made our determination in terms of the allocation, and then go into where we are as it relates to the allocation. So one of our primary areas of focus was equity and racial equity, because it was my particular lens, only because I'm immediate past president of the National Medical Association. So just the definition, what you see, the distribution of resources and opportunities neither determined nor predicted by race, racial bias, or racial ideology. And I won't say a lot more about this, but just that simple fact that when you reach health equity, you've reached equity, period. Because what we have found is when you factor out everything, socioeconomic status, underlying medical conditions, you still have adverse outcomes for African Americans, and it's due to racism. So when we have health equity in terms of African Americans and the majority community having the same outcomes, there'll be equity within society, period. And then this is just a simple graphic that I'm sure many have seen, just to differentiate equity from equality. Equality says give everyone something. And it's interesting, like in these checks coming from the government, give everyone a $600 check. No, some people could use a $6,000 check and some don't need a check at all. So equity is on the right, where you give people what they need to get to where they need to be. So there have been some disparities in COVID-19. And basically, these are the reasons. There are three primary areas. And as noted, underlying conditions, social determinants of health, and racism. I'm not going to spend a lot of time on that. I do want to note this, though. I may even ask for Dr. Balmer to comment. On the CDC's website, these are areas that are demonstrating increased risk for an adverse outcome. So serious heart conditions such as heart failure, CAD, or cardiomyopathy. Now, on the website as of now, it still states that cerebrovascular disease or hypertension might put you at higher risk. I just want him to comment to determine if that is might, or has it been conclusively determined that you're at high risk for a severe outcome if you have hypertension or cerebral vascular disease. So can you make a quick comment on that, Bill?
Sure. It's been an interesting aspect since the beginning, because obviously hypertension was associated with increased incidence of COVID, incidence of getting admitted to an ICU if you had COVID, and actually increased death. The difficulty is the risk of hypertension, separating it from the risk of age, because as we all get older, hypertension becomes more prevalent in the community. And the idea has been given that if you achieve the age of 55 years of age, that 90% chance you will develop hypertension during your lifetime. So it is quite prevalent as we get older. And obviously, since the COVID works especially well in the depressed or reduced immune system, as you get older, your immune system not only changes, but its response to a viral infection may be less, and your inflammatory or pro-inflammatory reaction to it could increase, which is associated with some, if not a significant part of the COVID damage that you get. So separating those out has been very difficult. And there are studies that show that perhaps that hypertension is not so much an independent risk factor, but it is associated with the older age, and that's what it's developing with. So I think that it's sort of dropped out of some of the risk-adjusted risk factors for severity of COVID once you factor in age. So I think at this point, it's probably age, It is cardiovascular disease, it is diabetes and some of the other cardiovascular illnesses. And there may be an association with uncontrolled hypertension that is still left, because if somebody comes up in with severe uncontrolled hypertension, that could contribute to some immediate cardiovascular problems.
All right. And I knew you'd have an answer, so I really do appreciate that. Now, this is where, as it relates, getting back now to allocation. So this was a slide that was developed by the ACIP work group and the CDC. And this is where we are. So phase 1, and this is going from left to right, that's time, and then going up and down on the y-axis, that would be the volume of doses. So we knew that at some point there'd be a release, and then there would be less vaccine than people. So this was the basic concept. So right now we're in this phase 1, where there's a quote unquote, this slide interestingly was developed like around August, September. So it says short period of time when doses may be limited. So this is where we are right now. So tightly focused vaccine administration, and then give it to those in critical populations first. So this is where we are now. So what I wanted to do was show how, Richard Figueroa could not go through this, but I think this is important for people to understand how and he mentioned some of it, but how the vaccine gets from the manufacturer to the arm. So at the state level, and so we review the enrolled providers, the state does. The state reviews the California Department of Public Health prioritization guidance, which is what the drafting guidelines group that I am co-chair of, is you allocate doses to enrolled providers according to guidance. So the state says certain people can provide vaccine. So those people are asked to request vaccine from the state, generally the local public health departments. They send an order into the state, and the state processes it. So then the manufacturer then sends it on to where it's supposed to go. So the vaccine doesn't go from the state from the manufacturer to the state. A lot of it comes straight to where it was to be administered. Now this has changed some. A lot of it is now coming to the state. So again, this slide is a little old, but there is some that goes straight to, let's say, Sutter, Kaiser, those that were mentioned. They may not come through the state. Some may come to the state, and then from the state to the county, and then from the county out to me, for example, we're vaccinating. So this is part of these are the logistical challenges. And during all of this, of course, you have to maintain cold chain. Pfizer is obviously the one at minus 94 degrees that has to remain at that ultra low temperature. Moderna is just a routine freezer temperature. So then the vaccine is received to those that are vaccinating. So we got 100 doses last week. So we have to store it and continue it in the cold chain requirements, and then we administer it. And then I'll get into more of the details as it relates to, it's not quite that simple. All right, so here. So we administer the vaccine. So now, summary of guidance for early vaccination. So this is what we are working on. I was actually on the ACIP work group. So this is where we started. Like, how do we allocate? So we looked at healthcare personnel, essential workers, high-risk medical conditions, and older adults. These are the people we knew that either were important to society as it relates to essential workers, or on the left, or at higher risk of an adverse outcome, either those with medical conditions or adults that are 65 and older. And the numbers are the approximate numbers in the population. And of interest is that you see that there's some intersection. So there are 65-year and older healthcare personnel that have high-risk conditions. So, there is overlap. And when you start to dole out the vaccine, you'll see that you already got to some of those people. So, for example, if I do healthcare personnel, then I look at those 65 and older. Well, some of those already got the vaccine. It was somewhere around 10%. That each time you go to another phase, they've already been included. And this did say it's needed for overlapping and needed for additional subgrouping, the bullet on the left. So that was where we started. So we knew subgrouping was needed. So now we are looking at essential workers. So these are defined by the state. There are 13 specific categories of essential worker, and these are called sectors. So that's important in the heading, infrastructure sectors. And that is different than an occupation. I think I put the occupation slide in here. So this is what we were working with when we said, okay, these are the sectors. So we have to look at essential workers and after healthcare workers and long-term care. This is who it goes to. So those were the sectors. Okay, so yeah, so good. So this is occupation. This is self-reported, and this is this data that is coming in. So industry shows a type of business. Industry data comes administrative data reported by businesses. It's based on where they work, and it's an official unemployment insurance file, whereas an occupation comes from household survey. What do you do as an occupation? It tells what the job actually is. It's tend to be based on where they live, and it's self-identified. So we kind of had to work with occupation versus sector. We more or less went with sector, then subdivided through occupation. So importantly, this what he mentioned is the Community Vaccine Advisory Committee. So the California state has 3 committees. The Scientific Safety and Review Committee, so strictly science. Okay, is this vaccine safe and effective? There was the Drafting Guidelines Committee. Who do we give it to? How do we prioritize? And then there was a third committee, the Community Vaccine Advisory Committee. Well, give advice to us from the community. How do you ethically allocate? How do you ethically determine the message? How do you interact with other community-based organizations to get the vaccine out? So we met with them, and this was their recommendation in terms of how you make your allocation. This is the effect on society. So that's why healthcare workers were important. If healthcare workers got COVID, they couldn't take care of the rest of us. Equity. So we want to ensure that those that are already having a disadvantaged effect of COVID-19 in terms of adverse outcomes got vaccinated. Occupational exposure. What is your risk for getting the virus and therefore having an adverse outcome? And then impact on the economy. And I will say this, that we put those 3, the first 3 I said, kind of at the highest level, and our feeling was impact on economy was kind of the least important as it related to when we prioritized. Like, for example, a banker may handle bonds, and you have billion-dollar bonds the California state may have to sell or manage, and that will affect the economy if it is not done properly. But we had a determination that they were not going to be there for the highest ranked individuals or in high priority. It was mentioned in terms of from Richard Figueroa, the numbers. So this is critical infrastructure work, excluding healthcare. So there are 8.2 or so million that are in those 13 categories. And so these are raw numbers. So this shows that there are more of essential workers than there is vaccine. So this is what we are also working with in terms of, how many people are in each sector, and then how do you sub-prioritize? So this was why it was such a challenge. I do believe I have in here a slide. Yeah, good. So this is 8.2 million people, right? So this is what we were working with in terms of what we were expecting to get in terms of vaccine. And this is for people. So there was the discussion earlier about, do you hold back? We were told that if you allocate let's say 2 million people there are 2 million healthcare workers. So don't think you have to allocate 4 million, allocate 2 million doses and we'll promise you'll get the second dose. But this is what we were working with. There are somewhere around 25, no, you saw the 11 million, but in terms of everyone in the state, there are about 40 million Californians. So we knew that this is what we were expecting, and we've gotten less than this. So it's been a real challenge in terms of the prioritization and then the distribution. I will say of the vaccine that California has in its possession, about a third of that has been given. So that's about 500,000 doses, which means we only have about 1.5 to 2 million. And looking by the end of January, we expected to have 6.25 million, and we don't. So this is what we basically came up with. 1A, healthcare personnel, and then long-term care facility residents. Long-term care facility residents account for approximately 35 to 40% of the deaths, and they are like 1% of the population. So they're at 100-fold risk, somewhere around there. There's exact numbers I don't have. So that's why they were put in 1A along with healthcare personnel. These are the approximate numbers in California of people. National data. This data in terms of the numbers is national data, not California data. So 24 million in 1A nationwide, 1B about 49 million nationwide, and then 1C 129 million. And then at the bottom, so this says accounts for persons recommended in prior doses, they already got it. So there's some people, like I said, in healthcare personnel that are also they're 75 and older, so they wouldn't be counted there. So again, we don't have enough vaccine for those people. Now, when Richard mentioned how do we balance, so this is the other thing. So I showed you societal impact, exposure. There were effect on economy, and what's the other one? I'm sorry. And equity. Yeah, I'm sorry, equity. So that's what we were working with. We were also working with these two primary areas: preservation of societal functioning, which I was saying, prevention of morbidity and mortality. So this is how we put long-term care, prevention of mortality and morbidity, societal functioning, healthcare workers, age, again, morbidity, mortality, and then you see 1C, age and underlying conditions. Healthcare personnel, frontline essential workers, and other essential workers. So this is how we were balancing things. This was more, again, on the national level. So what happened when the ACIP group made the determinations, we kind of followed them at the California state. So now let's look at it. This is where we are in California. I showed you this. That's 1A, and then 1B. So 1A is where that's set and that's done. 1B is where we are now moving toward. So this is, I'm going to say to you guys, this is proposed. This has not been determined in terms of what you're seeing in terms of well, actually it is. Actually, Richard told me it was. It's hard when you're on these committees to know what's public information and what's confidential. But this is where we are right now. So with the sub-prioritization, agriculture and food, education and childcare and emergency were felt to be the most important of those 13 sectors, primarily because people need to have a food supply. Educational and childcare, the feeling is that if we get the teachers vaccinated, then children can go back to school and others. And emergency services, I guess, for obvious reasons. And then for age, they're high risk. So 1B, critical manufacturing, industrial, commercial, residential, sheltering, facilities and services, transportation and healthcare and public health exposed that didn't get it in 1A. Like you were in 1A, but you were the CFO of a healthcare site, and you were at home all the time, so you had no exposure. And then the age, because again, 65 to 74, and then congregate setting. similar to this long-term care. When you're in a congregate setting, it can lead to outbreaks, if you will. And then 1C were the other sectors that were not in 1B. These, and so they have, you see them here, these 1, 2, 3, 7 sectors, and then age, anyone 50 to 64, and then 16 to 49 with an underlying condition. Some of this was also determined on practicality. How do you make clear that you're 41, but you have hypertension, or you, well, let's even go to something major, like you immunosuppressed, you know, your anti or cancer medications. So it's hard sometimes to prove that if you're going to go to Walgreens, say I'm 42, but I have a coronary artery disease. So age, you can prove. So that was one of the reasons why we did it this way. And there's just a few more slides. So this is how very general slide with very general numbers on the weeks in the bottom. So as you roll through phase 1A, which is kind of where we're now, we're getting almost through in the state, a lot of 1A healthcare workers, long-term care facility, not so much. But as you move through 1A, you move to 1B and then to 1C and then to phase 2. So it's not you vaccinate everyone in 1A until you start 1B. And this is also very challenging, I might add. So they wanted me to show my experience here. So the way it works in this, at the practical down on the ground level, we had to enroll in something called COVID Ready that allowed us to attest our ability to receive, store, administer, manage side effects, and report accurately. Then we had to receive approval from CDPH. Then they, not us, contacted the LA County Department of Public Health, say, okay, Watts Health is ready. You know, we've given them approval. So then the county informs us, then we enroll in something called PrepMod. PrepMod is a software, what's a program, or just a link, I'll call it. And it allows for people to go online and make a quote unquote appointment here. So this is now, it's private or public. Right now, Watts is private. We're only vaccinating our staff. So our staff can go into PrepMod and say, I want to get a shot at 11 o'clock or 2 o'clock. So it also allows LA counties to document our activities because they follow this. So administrating the administration, ordering the vaccine, staff and public to schedule the vaccine, to receive information, get vaccinated. So when you do this also, you attest to the fact that I understand that there are side effects, et cetera, et cetera. Then we vaccinate the person. We get the vaccine in. So that's right, I had to do this. Then we got the vaccine. We finally got it last Thursday. We have to put together a team to do the vaccination. We have to prioritize among our staff based on those guiding principles that I showed you. Who gets the vaccine? Then you vaccinate, yay. Our first people are being vaccinated in 6 minutes at 1 o'clock. Then we report this back to the LA County DP, Department of Public Health, and then we order more vaccine. It was noted that we want to be sure that people know there is monitoring in terms of safety. So this is, they call it post-marketing, it's phase 4. So that for the general public is out there, there's VAERS, the Vaccine Safety Data Link, there's the Clinical Immunization Safety Assessment, CISA. These are all either FDA, CDC, yeah, as seen on the slide. These are there, these are always in place. So when you start giving vaccine, it's like, okay, good luck. So this is there. Also, Department of Defense has theirs, veterans have theirs, tribal nations have theirs. But it was determined that we should have an extra level for this particular vaccine. It came through emergency use authorization. This is the first time we've had a vaccine in wide use like this under emergency use authorization. So there was something called vSafe. That's a smartphone link that allows to check in with vaccine recipients. And then the NHSN, the National Healthcare Safety Network, which was developed by the CDC to monitor what was happening at acute and long-term care facilities. So I just wanted people to know that there are existing and expanded safety monitoring systems. So now there's been a lot of discussion about jumping the line, quote unquote. So this came out of Sacramento Bee. the 28th, and then it was updated 29th. So this was what, 12 days ago, something like that. You will be sanctioned, the governor said, against COVID-19 line skipping. So he stated this day that we're forced to order people receiving vaccines, issuing a warning to medical providers who may be tempted to cut a friend or relative in line to receive the shot. So I want to make this crystal clear. If you skip the line or intend to skip the line, you will be sanctioned, you will lose your license, he said during a press conference. You will not only lose your license, we will be very aggressive in terms of highlighting the reputational impacts as well. And I will say that in the guidance of those things we got from COVID Ready and Prep Mod, it does say that you need to, monitor and follow the criteria. So, again, me first. So my statement is, well, yeah, I did actually get to go first because this was taken in the lobby of Martin Luther King Hospital, where I was happened to be finished my rounds on the ward. So I have direct exposure to patients. And I will say on Sunday, yesterday, all of the mothers that were up there were COVID positive, 3 for 3. So it is out there. I was happy, I will say, to get my vaccine. So thank you very much. And at this point, Hattie and Dr. Bomber, I will be open to any questions.
Well, thank you very much for that comprehensive review and your efforts on not only the National Medical Association, but also on this COVID area. So I think we have a few minutes for questions that we can do. Let me throw out a interesting or provocative one first. And that is from the committee's perspective, one of our former legislators held actually the Speaker of the House for California put out a proposal. Why don't we turn back from the current restriction and distribution system to what we did for polio? So Willie Brown, who you know, advocated that why don't we just send it to schools, set up and distribute it on the day it arrives from the school systems. We can get in public health nurses or other volunteers to administer it and get it all out on the day it arrives instead of having it on shelves or in transport.
Yeah, that's to me like the old KISS, keep it simple, stupid.
Yep.
That's a very compelling argument. I'm not going to say that I disagree with that. I think the concern might be the cold storage, which, if I remember when I got my little polio cube, I don't think it was cold, but I still remember it to this day. I don't think that's a bad idea. I think that it may, as we move forward through this, probably when we get the fate, because I think part of that would be ensuring that the people getting it are those that are prioritized appropriately. But I guess theoretically you could put that in place. My guess is when we get to phase 2, where it's like the general population, that there may be something as simple as, right, go to your local school, anyone show up, all you have to do is show up. I mean, you don't have to prove anything other than you're there. So, it's funny, when we meet again, which will be, I think, this week, I'll mention that. I'm serious. I think it's not a bad idea.
Dr. Brooks,
Any other questions?
this is Matt Budoff. I was just wondering, is there any way to speed up long-term care facilities? They make up 40% of our ICU right now.
Yeah, so I called my CVS yesterday. They don't have a CVS, and Walgreens is supposed to be doing it. And it's a good question, Matt. That question is more appropriately directed to the state. We at our drafting guidelines made it clear that we're not the ones to deal with the logistics of the distribution and administration. We make the determinations, and we don't have any control over that part, and it's really frustrating. So they definitely need the vaccine. I'm not real clear on again, that was supposed to go through Walgreens and CVS. I am not real clear on why they haven't gotten it. And you're right, they should make up 40% because they're making up 30 to 40% of the ICU and the deaths.
So Steve Chan, you mentioned on our leadership call recently that the pharmacists in West Virginia have vaccinated all the long-term care patients. Is that right?
Yeah, and the story's even better, right? West Virginia is at 72% in terms of their use of allocated vaccine, and they have very widely deployed pharmacies in that effort.
Yeah, okay, and
So,
go on, Hattie.
I just wonder, how is that being engaged for California? Steve and Cindy, who are from the front lines of the pharmacy leadership world.
Yeah, to Dr. Brooks' point, it's starting to roll very quickly. In LA County, as of today, 70 pharmacies that didn't have access to the vaccine have it now for the first time. So I think it's moving up quickly, thankfully.
And there's a question, and thanks, Stephen. That's great news.
Yeah,
and Matt should be happy about that too. There's in the box. How do you at the local level get the information out about VSafe? I think that one thing I didn't touch on at all is messaging. So we need to be actually having more messaging. We need to be flooding the airwaves, social media, radio. It is important that we have VSafe engagement using this smartphone application. The more data we will have on the vaccine. And is there a need for retired physicians to volunteer? You know what? I don't think so. I think that there's enough infrastructure right now, I believe, to get the vaccine administered. If you think about it, the log jam is not people to do it or even systems to do it. It just seems like getting the vaccine out and having the regulations all met. But there is some there that has been discussed in terms of Gerald Bourne, who asked that question.
I was going to add that.
Go ahead, Steve.
Sorry, Hattie. I was going to add that there are retired pharmacists that are coming out to volunteer. As a part of their volunteer work, they are getting vaccinated, of course. And we're finding that that's critical because, for example, Dodger Stadium is going to open up this Friday as a site where thousands of vaccinations will be given per day. It's going to require a significant number of pharmacists to at least supervise pharmacy students that will be involved in that effort.
Okay. And one thing we did say, anyone who is providing vaccination services should be vaccinated. So I'm glad you said it too. And so maybe the answer, as we ramp up there, and I have to think about that, there may be the need for volunteer, retired, like we did determine that pharmacy interns, that they can be involved in the process.
So Oliver, we had discussed earlier your important role on that committee. Two of the things that we were thinking was, and had discussed earlier, was perhaps could the committee recommend or further recommend to the state a metric where we can show for the state of California on a daily basis the number of individuals who have been vaccinated, for two reasons: reassurance to all of us that this is actually being implemented and we're focusing on it, number one. And two, reassurance for people who are perhaps hesitant to get vaccinated if they say, hey, 4 million, 5 million people in California already have been vaccinated and the numbers going up every day. It's sort of a join the group, and you're in a large group that is on its way to successful vaccination.
Yeah, so I think that having that metric would be very important. I almost want to say that I saw something like that, and as we, before the end of this meeting, I'm going to see if I can find that link. But I think that will breed less hesitancy, or in the positive statement, more confidence. people have been asking me, did you get vaccinated? When I was on the floor at King right there, I mean, the nurses were asking me, did you get your vaccine yet? And I started realizing it wasn't just curiosity. They were like, if you get it, it kind of means something. And so that was one of the reasons we also chose healthcare providers to be in phase 1A, because we were hoping that healthcare providers could lead and others may follow. That metric, I think, would be excellent, Dr. Balmer. And if it's not there, I will definitely state it, or even whatever metric. I mean, the metric of how much we've gotten in, how much has been out, whatever we have. It may not be actual shots in arms, but it could be, other metrics and clear metrics. So yes, make a note of that.
Other questions on COVID response?
I think it's such a rich topic, and many of us would like to talk about it at length, hear what's going on at the different institutions. I know Dr. Oliver Brooks was mentioning the frustration of how difficult it was to get the supply to start vaccinating. Maybe you can just say a little bit about that while we start transitioning to our cardiology speaker from Stanford on advances in lipid management.
Well, I will just say that we wanted it, and it's more than a notion. I mean, I showed you the things we had to go through. We get ours from the county. County only has Moderna, so it was a short-term frustration, I have to say, Hattie, because I understood the challenges that were going on. I think what people want, I didn't say this, but I think that when people are having the issue of why did it take so long, why we're frustrated, the vaccine was approved by the FDA. One was, I want to say December 10th and December 17th. That feels right, close, right in the holiday season. Public health is dealing with the biggest surge they've ever dealt with in the history of the US in the last 102 years. So they're not just dealing with vaccine allocation and distribution. Contact tracing, ICU capacity, oxygen, PPE. Public health is generally underfunded, so they didn't theoretically have as many people as they needed. And then some of them were getting sick. So you put all of that on a county public health department, and they're just going to be strained to the end. But I'll say one last thing. I talked to one is managing things here, and she said, I love it. I said, well, you're working 12-hour days. She said, I've been doing vaccines all my public life, professional life. I love it. So I just want to let the group know that those in public health, even though they're getting squeezed and they're working harder than ever, they believe in what they're doing.
Well, we really appreciate your wonderful presentation and your dedication to the cause. And, hopefully we can resume some questions and discussion about that piece after our formal time here until 2. We have an amazing cardiology leader with us, and I'll let Dr. Balmer formally introduce Dr. Levin from Stanford. But I just want to say that her work in leading the development of Northern California cardiology programs for Kaiser over a period of decades is nothing short of phenomenal, and we are so excited to hear her speak. Dr. Balmer, I'll turn it over to you.
All right. Well, thank you very much, Oliver, for all you're doing. And we're unfortunately in a situation where we have a high death rate from COVID, and that has not cured our high death rate from cardiovascular disease. So we also want to focus on the continuing high risk of cardiovascular disease to our patients. And to do that, we've asked Eleanor Levin to come, and she has received her training at Georgetown University and did a lot of work as lipid research. So she has a very good background in understanding lipidology as well as cardiology, focusing on echo and on CT angiography. in her years of work at Kaiser Hospital in the Bay Area. She did emigrate from Kaiser 2 years ago to Stanford and is now a clinical professor in cardiology at Stanford University, specializing in 2 areas: preventive cardiology, which we'll hear about today, including her focus on lipids, as well as cardio obstetrics, where she has had an interest for many, many years for the individual for cardio obstetrics. So it's our delight today to be able to present Eleanor Levin from the Stanford University, who's going to discuss on current lipid therapy. Dr. Levin.
Hi, so I'll just get going because we don't have much time. Could I share my screen, please? Because I updated my slides from one typo.
Sure.
It still says disabled.
Megan or Jen, if you can.
share.
Okay, okay, great, thank you. Okay, here are my disclosures. I'm a scientific advisor for Moving Analytics that does home-based cardiac rehab, and a consultant for AliveCor, which does remote monitoring. So we all know what goes wrong in atherosclerosis, but basically the LDL gets into the epithelium and with the macrophages and causes these foam cells, and you end up with atherosclerosis. And our risk factors we can't do anything about are age, family history, gender, postmenopausal status, but those that we can work on are hypertension, diabetes, dyslipidemia, obesity, sedentary lifestyle, smoking, and stress. So these classic risk factors are identifiable, but 50% of one's lifetime risk is actually from environmental factors. All of these risk factors work synergistically. So for example, if you're diabetic and you smoke, you have a much worse than if you're either, it's not the additive, they're exponential. Cholesterol is made by the liver, but it also comes from animal-based food that we eat. These are the different lipoproteins. There are several HDLs, the good cholesterol, which I tell patients is the vacuum cleaner of the heart. And then ApoB is of several components. Lp(a), of which we don't have very much therapeutics yet, but it is a risk factor for coronary disease. LDL, the so-called bad cholesterol, intermediate density lipoproteins as well, and very low density lipoproteins, where the triglycerides are the main component, as well as chylomicrons. There's great support for the LDL hypothesis. Believe it or not, when I was a fellow, this was a debate, but many, many studies have shown, finalizing recently and improve it, where the lower your LDL, the lower your risk. The 2 top killers are heart disease and cancer. And if you look at this graph, I came to Kaiser Permanente in 1989 and started the cholesterol management programs. At that time, heart disease in Northern California, Kaiser patients was still the #1 killer, and cancer was #2. But by the year 10,000, the year 10 years later, the year 2000, we were able to report that heart disease in Kaiser Permanente, Northern California, was no longer the #1 killer. And cancer was the #1 killer in spite of advances. and heart disease was number 2. And it has improved across the country, although still number 1 heart disease. But in Kaiser Permanente, heart disease, morbidity, mortality continued to drop and continues based on our phase program, Prevent Heart Attack and Stroke Every Day, which the care management programs I instituted morphed into. And heart disease remains not the number 1 killer. There are common misconceptions about the 2013 guideline, that it required initiation of statin, that they're set and forget, that there's no role for non-statin agents, no compromise about dosing, not useful for elderly patients, and that orthogonal data was useless. This was all not true. The DREAM cholesterol profile is the total cholesterol less than 200, LDL less than 100, or even better, less than 70, HDL greater than 60 for women, greater than 50 for men, and triglycerides less than 100. We encourage 2 kinds of diet in our preventive cardiology clinic. One is a Mediterranean diet with olive oil, lots of vegetables and plants, and then easily the DASH diet, especially these are both good for blood pressure and lipids. There is an Asian equivalent, the Okinawa diet, which also is very heavily plant-based. The 2015 to 2020 dietary guidelines from the National Scientific Report recommend higher amounts of vegetables, fruit, whole grains, seafood, legumes, and small amounts of nuts with low and non-fat dairy products. So we suggest make half your plate fruits and vegetables, half your grains whole grains, move to low fat and fat-free dairy products daily, vary your protein, try to avoid lots of red meat, reduce sodium to less than 2,000 milligrams if you can, and reduce saturated fats and sugar. In addition, for pre-diabetic patients, I recommend avoiding the white carbs, which is white bread, white rice, white pasta, potatoes, but sweet potatoes and brown rice are okay. So part of it, of course, is portion sizes have gone up. The bagel has morphed from 140 calories to 350 calories. When you increase the diameter, you can increase the calories 2 to 3-fold. And this also includes French fries, sodas. So these are working towards a healthy diet. So there was a new guideline in 2018, AHA, ACC, the National Lipid Society, to try to reduce the misconceptions from the 2013 guideline. So we emphasize heart-healthy lifestyle at all ages, weight management, stress reduction, smoking cessation. Genetics does not equal destiny, and so we can improve this. And here's a copy of the primary prevention guidelines. Notice the risk enhancers: family history of premature atherosclerotic disease, persistently elevated LDL greater than 160, chronic kidney disease, metabolic syndrome, preeclampsia and premature menopause in women, inflammatory diseases like rheumatoid arthritis, psoriasis, and HIV, ethnicity like South Asians and Filipinos, and persistently elevated triglycerides greater than 175, and also factors that make us reduce our LDL goals and institute treatment at a younger age, including high sensitivity CRP greater than 2, Lp(a) greater than 50 milligrams per deciliter or greater than 125 nanomoles per liter, ApoB greater than 130 milligrams per deciliter, and peripheral vascular disease. So in patients with clinical ASCVD, we reduce the LDL with high intensity statins to reduce risk. And this includes stroke, TIA, CAD, bypass, PCI, and ACS, PAD and AAA, and a calcium score CT can help clarify the risk. So this was a new inclusion on the guidelines. Many of the insurance companies have not caught up with this, and we often find that CAC-CT is not covered by insurance. We've tried locally to get very cheap CT scans to help us with this so patients can pay for it, but it's still in the range of $100 to $150 for a calcium score. Here are the secondary prevention guidelines. And again, one thing I do want to point out, if you're on maximal statin therapy and your LDL is still greater than 70 in a secondary prevention patient, adding ezetimibe might be reasonable. And in addition, if you're on both of those, high intensity maximum statin, you've already added ezetimibe, and you're still above goal, you should consider a Psk9 inhibitor. Very high risk, as I said, you add ezetimibe, and if not a goal, add Psk9 inhibitors. Now, severe primary hypercholesterolemia, we don't bother with the Framingham data. We go ahead in the familial hypercholesterolemics and begin the high density intensity statin, and again, the other two steps as needed. If patients are in this 40 to 75 year age group with diabetes and an LDL greater than 70, we do a moderate dose statin. If they are smokers, have hypertension in addition, we will add high intensity statins. And very high risk patients, we start high dose, we do not pause. These are patients over 65, heterozygote familial hypercholesterolemics, diabetes, hypertension, CKD, current smokers, persistently elevated LDL despite statin, and a history of heart failure. In age 40 to 75 without diabetes and LDL greater than 70 and a high 10-year risk, we do moderate, but consider if they have family history of premature coronary disease, LDL greater than or equal to 160, metabolic syndrome, history of preeclampsia or premature menopause, chronic inflammatory disorders, South Asian or Filipino, CKD, high triglycerides, high sensitive CRP, Lp(a) elevated, we want to initiate the statins at an earlier time. I find the calcium score in CT is useful, particularly if you want to make your goal, because if it's 0 without any of these risk factors, we might hold off on treatment, continue diet and lifestyle changes. If the CAC is greater than 100 or the Lp(a) is greater than 50, then in our clinic at Stanford, we start a baby aspirin. And this shows you what can help you make these decisions, some of the coronary calcifications. In most cases, I also look if there was another reason the patient had a CT scan of the lungs, for example, or for some other reason. Even sometimes if they have neck CT, they'll go down as far as the heart, or an abdominal CT, they'll go up to the heart. I will look for coronary calcium there as well. And that will make me more likely to make a lower goal and consider baby aspirin. And then we repeat the lipid panels after adjustment. This was not in the 2013 guideline. So again, these are a summary of some of the major statin therapy. So before I go to the cases, I want to make this smaller. I'm going to come back to the cases. I want to show you phase on a page. So, which is what we developed at Kaiser Permanente to make it easier to do the right thing. So let's go here. Hold on. Where's my little clicker here? For some reason, this did not end up in my slideshow. Hold on. well, I'm going to do it this way. I'm just going to go.
No, he was not.
The last.
Dr. Levin, do you need any help from our staff?
No, I've got it right here. I think we're still sharing, right? So
Yeah.
I want to show you, this one is from November 2019. So it's always continually updated. But what we did is we took what is done in all of the chronic care conditions management programs, and we put it on one page. So it can be laminated. It's in the nurse practitioner or the primary care physician's pocket. It helps them know what to do. So basically puts it all on one page, the blood pressure goals, a recommended algorithm right here, statin goals, recommended algorithm, A1C goals, and recommended algorithm with some of the newer agents, and telling you who these phase populations are and different things about the different drugs with recommendation of labs. This is available on the internet, and we made it available to the public, and it's really incredibly useful to have it all of your prevention in one spot. So I just wanted to bring your attention to it. It's called Phase on a Page, and the latest one that is available at careinnovations.org is the November 2019. Since November 2019, most resources have been redirected toward COVID, but this is still very, very up to date. So I wanted to bring your attention to that. Now I'm going to go back to the case studies. Any questions while I'm skipping back to case one? So the first case, interrupt me with anything, guys. 39-year-old Hispanic man presents with myocardial infarction. Non-STEMI troponin peak is pretty low. Risk factors are smoking, cholesterol, hypertension, diabetes, family history of early CAD. Here's his lipid panel. This is familial hypercholesterolemia. No risk stratification needs to be done. It's very unlikely that high-dose statins are going to do the whole job, even with ezetimibe. This patient will likely need Psk9 inhibitors. It's a severe elevation. The LDL is 4 to 12. This shows the family history of this patient. Familial hypercholesterolemia has a presence in the United States of 1 in 250. 50% of untreated men will have an MI by 50. It's a cause of 2 to 4% of all heart attacks in the United States before age 60, and it's worth looking for and treating. A lifelong exposure to high LDL causes early coronary disease, so we should be treating when they're children, and the heterozygotes, we should be treating when they're teenagers. Years ago, when I rotated through pediatric lipid clinics, we were not starting statins in this age group, but we now know this is very important. In people who have these familial hypercholesterolemics, but are not necessarily this type of familial hypercholesterolemia, I am starting statins in men in the 30s and in women in the 40s after they've finished childbearing. I'm not waiting until they're 50 or 60 when they have these familial type problems. So diet and lifestyle are important with high soluble fiber, reduced saturated fat. Statins are the mainstay. You have to use 2 or more drugs, including ezetimibe, but you might have to add Psk9 inhibitors. Treat the other risk factors. Do not use standard tools to estimate heart disease risk, including age. They are inaccurate. So this just tells you what high intensity, moderate intensity, and low intensity are. I want to put a few caveats in here in terms of statin intolerance, that there are certain statins which are lovastatin, simvastatin, atorvastatin. These are lipophilic statins. You tend to have more muscle aches. They cross the blood-brain barrier, so you can get this quote unquote foggy thinking. They do give you more liver problems. So the hydrophilic statins like pravastatin and rosuvastatin tend to not get as much liver dysfunction, not cross the blood-brain barrier. So if you get a patient who says, oh, I'm getting nightmares, which does happen with simvastatin and atorvastatin, you just switch them to pravastatin or rosuvastatin. It does not go into the brain, and it does cause less muscle aches. So I wanted to bring that up. This is Psk9 inhibitors. They're available. They are difficult to get approved, but in patients who have familial hyperlipidemias or familial hypercholesterolemia, it's an easy approval. And for patients that you've already tried maximal statin with ezetimibe and not at goal, it is possible. So we're going to skip now to the, because in the interest of time, I want to get to the case studies. Case 2, 53-year-old man, asymptomatic, overweight, total cholesterol 220, LDL 160, HDL 35, triglyceride 100, blood pressure 135/85, not on meds. This is stage 1 hypertension. You need to institute lifestyle changes, not a diabetic, not a smoker. 10-year risk 8%, hard outcomes with Framingham 9%. You institute a high dose statin. You institute lifestyle changes for the hypertension. After 3 to 6 months, if still stage 1, consider medication. So in this case, you could do rosuvastatin 20 or atorvastatin 40, increase if not at goal. Goal for this patient without a CT CAC score would be less than 100. If there's calcium in the CAC score, I might push it to 70. And if not at goal, add ezetimibe. If not at goal, consider Psk9 inhibitor. 33-year-old woman, asymptomatic, a life insurance physical, has a normal blood pressure. However, the LDL is 210. Mother had an MI at age 55. What to do? Do not use the risk calculator. This is familial hypercholesterolemia. Initiate high-dose statin with Plan B supplemental contraception. When she decides to get pregnant, stop the statin. It's an X drug for pregnancy. And then after the pregnancy, you can consider restarting and screen the relatives. So this again repeats that. 67-year-old African-American woman, total cholesterol 220, LDL 125, HDL 50, triglycerides 75. Non-smoker, non-diabetic, blood pressure is well controlled on therapy. The risk calculator is high. The hard risk is 5% on Framingham, but I would initiate a high potency statin. Even though the LDL is 125, this patient's greater than age 65 hypertensive. Again, the usual. This patient was started on atorvastatin 80, got myalgias. There was a new study just released in the last heart meeting about not placebo effect, but nocebo effect. So what they found is that patients who were on statins did get aches and pains, but it really was not related to the statin. In this case, we switched to a hydrophilic statin, and the patient then is able to tolerate only 5 milligrams a day. Repeat LDL still above goal, added ezetimibe. 45-year-old obese male, type 2 diabetes. Blood pressure is in stage 1 on therapy. Total cholesterol 210, LDL 140, HDL 35, triglycerides are elevated, non-smoker. Question? Nurali? Oh, Nurali's on, but no question. Okay, has diabetes. No question, add a high potency statin, okay? Don't use the calculator. Trial of rosuvastatin 20 or atorvastatin 40. If, again, not at goal, increase dose, at goal, add acetamide. If at goal, consider Psk9 inhibitor, not at goal. 60-year-old man with prior MI, status post-PCI to the LAD, history of hypertension on ACE inhibitor, pre-event lipids, total cholesterol 200, LDL 165, HDL 45, former smoker, not diabetic, on aspirin clopidogrel, started on atorvastatin 80, tolerates well, repeat lipids are good. So they're good, but this patient is a coronary patient, okay? So if you have a coronary disease patient, we push the LDL now less than 70. That's part of the new guidelines. So we would consider ezetimibe 10. Now, what I have found, by the way, is that rosuvastatin seems to be more potent than atorvastatin. So if this is a non-Asian patient, because Asian patients, you have to keep a reduced dose of rosuvastatin, then I would go with 40 of rosuvastatin. So remember that for Asian patients, you do have to reduce the statin dose. So you might have to add ezetimibe sooner. 44-year-old man, smoker, stage 1 hypertension, LDL is elevated, HDL is decreased. Lifetime risk is 70%. The 10-year risk is not that high, but I would still consider a statin, definitely have the patient stop smoking. In this kind of case, when you're on the border, I would get a coronary calcium scan. If it's 0, I might give them some more time with diet and exercise, but if it's elevated, I would just treat high dose and get it down. So another case where a calcium score really helps you as opposed to just the guidelines. 57.
Can I ask you a question?
Yes, please.
So when you say a score would be helpful, my personal opinion is that anything other than 0, I don't care if it's 5, 50, or 105, deserves therapy.
Correct. But without the, what if it's 0?
So zero I don't have a problem with. 0 I don't have a problem. It's
Yes.
For me, it's
No,
the attempt to try to nuance things with
No. Well,
anything other than a positive
Carlin,
score.
it helps you for aspirin, for baby aspirin. Because
Agreed.
there's some
Agreed.
risk that if you use baby aspirin in primary prevention, there's increased risk of bleeding related to benefit. Now, if you look at calcium scores, once it gets above 100, there's a linear relationship with MACE events with the calcium score. Below 100, it's pretty low. So generally in our clinic, if the calcium score is 100, it tells us we're going to start a baby aspirin.
I agree completely. Thank you.
Okay, great. Thanks. This is one of those intolerant of statin patients, muscle aches with atorvastatin, diabetes type 2, stage 1 hypertension, LDL is elevated. Trier of a hydrophilic statin, stop the atorvastatin. There is this nocebo effect, but usually with encouragement, we start it once a week, and then if tolerated, we then go to twice a week, and then increase as much as the patient will tolerate. If not tolerated, then you can usually use Psk9 inhibitors. 49-year-old woman, non-smoker, blood pressure 125/75, LDL 125, HDL 50, Lp(a) is 103, family history of early MI in the mother, maternal grandmother, what to do? Well, we don't have a great drug for Lp(a) right now. You could use niacin, but it's not as good for the LDL. So, and then you have more side effects. So we generally are adding a statin and reducing the LDL to the 35 to 45 range. We're adding a baby aspirin right away with Lp(a) that's elevated. And Novartis has a drug, they're about to start trials of it. but currently there are no treatment options for Lp(a). So I want to go back to the phase on a page and let you know that this was created with the cooperation of the vascular surgeons, the neurologists, the emergency room physicians, because these phase populations for secondary prevention include also CVA and TIA, they include symptomatic PAD, and they include diabetics. So we basically got all these people in a room. We got the neurologists, the vascular surgeons, the endocrinologists, the emergency room physicians, and the internists and cardiologists, and the pharmacy people. And we came up with these guidelines to all work together so that if a patient comes into the emergency room with the TIA, and they don't necessarily have to see a neurologist at that visit at 2 in the morning, and they're sent home, they're sent home already with a statin, already treating their cholesterol, already treating their blood pressure. So it's basically an integrated approach. So I just wanted to bring up that when we first started, we were just the cardiologist, but we found in our studies, 20 years ago, that there was a reduced incidence of stroke in those patients who had their cholesterol treated by 30%. So it was wonderful when the neurology studies came on board and showed similar results in patients who had atherosclerosis, but not necessarily coronary in terms of stroke reduction. And so I just wanted to bring that up as a comprehensive guideline. Now we have about 10 minutes for questions and comments. Thank you.
Thank you very much, Eleanor. That's a very excellent presentation. And I like the use of your one-page outlines, even though there's 6 pages on that, or?
It's basically 2, I think, right
Okay.
now. They got it onto 2. The September, the year before, had gone up to 3, but they were able to reduce the print and whatever, because they needed to get all of this stuff on for the diabetes. And they were able to get it down to 2. So it's 2 pages. This is the November 2019.
So Right Care has done this with the state of California CDPH for hypertension, and perhaps we could look at advancing to adding this more comprehensive lipid approach as well for that. I noticed in your recommendations that you had certainly recommended fish for individuals in their diet. For the individual with existing cardiovascular disease, where do you fall on the supplementation of EPA and DHA for individuals that have a triglyceride over 135? Should that be added for secondary prevention? And
Yes,
do we need
yes.
to monitor EPA levels in those individuals to
No.
make sure they're getting adequate amounts?
Yeah, well, I'll just tell you my personal approach. David Marin in my clinic has a slightly different approach. So my personal approach is, partially because I came from Kaiser, is I use generic fish oil. And I've used it for 25, 30 years to reduce triglycerides, particularly because I would be referred patients with very high triglycerides who had had pancreatitis. So I would use niacin and fish oil up to 4 to 5 to 6 grams a day in those patients. Now, in patients who just have a mild elevation of triglycerides, I first try to get them, if it's just less than 300, is to get some weight loss and avoiding the white carbs, because usually they have pre-diabetes and metabolic syndrome as well. But then if it continues elevated, I'm usually into the fish oil 1 to 2 grams a day. If you freeze the capsules, they're less fishy and they're more tolerable. Now, David has a different approach because of the studies with the commercial fish oil preparation. I have some problems with the study, as does our endocrinology division, because they used mineral oil as their placebo. So that makes the commercial fish oil purified seem more effective than it might really be because of the mineral oil. But he tends to use the commercial product that's a pharmacy product. And the problem is many insurance will not pay for it unless you have elevated triglycerides that did not respond either to generic or some other way. So it requires a prior authorization and it's quite expensive. And neither of us check levels, neither of us. That's in a nutshell what I do.
Do we have any other questions for Eleanor?
Yeah, if you have any lipid questions, like fire away.
Oh, hey, Eleanor, great talk, thanks. I'm just off video right now. This is Nerali, stroke neurologist at Stanford. I wanted to ask about expanding on this Asian patient dose adjustment, because I don't think we're doing that in neurology, and I'd like to know a little bit more about where that came from and the subgroup of Asian that refers to.
Yeah, that's critically important. It's Chinese, but it's other Asians as well. Hold on, let me move it down here. Asian. And you usually, the max dose is about half. So this is from the NIH here. It's been reported for about 10 years.
And you do this even in secondary stroke prevention?
Yes,
stroke patients are all on placebo 40.
Yes, I'm sorry, but you do have to reduce it. Here are all the different studies with all these different labs and all these different meds, and you do have to reduce it. Often the pharmacy will catch it and reduce it for you, but it becomes unsafe because they get too high a level.
Eleanor, there's a couple questions on our post that have been posted. One is, can you define familial hypercholesterolemia, the exact definition that you use for it?
Okay,
then,
well, there's two things. There's high cholesterol that runs in families, and then there's familial hypercholesterolemia. So the familial hypercholesterolemia, of which there is a national foundation that Josh Knowles at Stanford, one of our assistant professors, is the physician lead for the national foundation. That is a recognized genetic, they're like different genetic abnormalities they can determine on testing. And those end up with a really high score. So that particular has to be determined by genetic testing and a genetic counselor. But then there are basically polyscore. This has not yet been prime time yet, but you can have multiple little problems with your genome where in your family, you have an increased family history of coronary disease and an elevated cholesterol, but not in the range of these other familial hypercholesterolemics, the ones that are determined by genetic testing. And this one will come out negative on genetic testing. And your LDL will probably be in the 170 to 200 range. So those patients I do treat aggressively, but not as aggressively in their teenage years as the familial hypercholesterolemics. So one is familial hypercholesterolemia, which is a known entity that you find on Wikipedia. And the other is familial hyperlipidemia, which is hyperlipidemia that runs in families, but is not one of these specific genetic diseases. Is that clear?
Yes, thank you. Two other questions. One was, you had said stay away from white carbs.
Yes, white carbs, particularly for
ones.
pre-diabetes, yes.
Would you be interested in pushing it to further to low or no carb or quote keto diets? Do they offer any kind of advantage?
Okay, so we have found with our wonderful dietitians that patients who go on one of these keto diets that they find on the internet, their cholesterol will go LDL from like 140 to over 200, with the ones where you eat bacon and butter and steak for breakfast. But there are safe ways to do a keto diet. And so in these patients that insist, because they're trying a keto diet for weight loss, she devises a personalized keto diet for those patients that reduces their carbs, gives them some complex carbs with vegetables, and does not use red meat, butter, bacon, but instead uses more fish and white meat chicken and egg whites and non-fat dairy. So she devises a personalized keto diet that is not high in saturated fat and has some carbs through the complex carbs and vegetables. But if they do one of these straight keto diets you find on the internet, we have found their LDL triples. Next question.
Great. We have another question in the queue is individuals who, let's say, qualify for a statin, and if you don't have side effects from the statin, why not just take the higher dose? You'll get an additional 6% to 7% reduction in your LDL. And if we believe in the LDL hypothesis, lower on the curve is a little bit better in slowing the progression of atherosclerosis.
I have no objection to that. Just in the Bay Area, we have to be very cautious. We have a high Asian population, and you have to make sure not to give them a dangerous dose of statins. So their max statin for rosuvastatin, for example, will be 20, it won't be 40. But I have no problem with giving more if it's tolerated. I do find that with simvastatin and atorvastatin, there are some, aches and pains. And then again, the caution with the Asian patients. Next question.
Let's open it up. Do other people online have questions they'd like to ask?
Well, since nobody is typing in, of course, I'll always ask a question. Dr. Levin, can you?
Yeah, after you're done, Hattie, someone had a question about CoQ10, which I'll do right after yours. Go ahead.
Can you talk a little bit about the mechanism of PCSK9 inhibitors?
Oh, I'm not a biochemist. I'd have to go back to the slides and go through the whole thing again. So, because I can't do that off the top of my head. Josh Knowles could. He works in the lab 80%. He's a wet lab guy, but I'm a clinician. So no, I'd have to go back to the slides and it would take like 15 minutes of.
No, it's okay. It's okay.
Yeah.
Bill, did you want to comment?
Yeah, well, basically it's fascinating. We all make a small amount of a protein called PCSK9, which circulates in the blood. And what it does is it attaches to our LDL receptor. And as it's brought into the cell, into the liver cell mostly, it actually destroys the LDL receptor. So all of us have LDL receptors that typically have the ability to go out and be re-expressed or recycled on the cell surface about 250 times. But if that LDL receptor winds up incorporating as part of the LDL and the invagination into the cell, PCSK9 protein, then it goes from a 250 recycle use down to 1. So you lose your recycling capacity, and that dramatically drops your LDL receptors, which are trying to remove the LDL from the blood circulation. And of course, we think that that LDL circulating is sort of the bricks that builds the cholesterol plaque. Atherosclerotic disease. So very effective drug that significantly lowers LDL in all individuals, including some with familial hyperlipidemia and even familial hypercholesterolemia. So it does lower LDLs dramatically on the order of 40 to 60% in those individuals. So effective as an additive to statin therapy. So all of the trials were done with statins, but to get with your statin a 50% reduction and then PCSK9 inhibitor an additional 50 to 60% reduction now allows us finally to get some of the hyperlipidemic patients with familial disease down into a reasonable range where a single agent was not able to do that.
And here's a slide from Josh Knowles and Fatima Rodriguez from my group. Josh does a lot of lab research on this field in the lab with technicians. And so here's a schema of what he was talking about, and the reference is down there. Current atherosclerosis. On a clinician, so I'll stop sharing that now. And then someone said CoQ10 placement. I use CoQ10. There's no good clinical, no good data on it. I just use it anecdotally because it's part of the nocebo effect. It seems to really help people, and but there's no clinical trials of any worth. But I have no objection to using it.
Eleanor, earlier on, you offered us a possible look into the year 10,000. And
sorry about that.
And I wondered, in the year 10,000, will we have realized that atherosclerosis is a continuing burden that develops early on, from childhood on, and we will perhaps have started therapy earlier to the extent that we can perhaps emulate Kaiser's way of getting cardiovascular disease not as number 1, but down to number 2, and maybe down to number 30 or 40, because we could potentially have the benefit of eliminating atherosclerotic disease as a morbidity for us as we get more mature and knowledge about this subject.
Well, I would say absolutely, because when I started these cholesterol management programs in 1990 at Kaiser Permanente, they told me, this is going to cost us a lot of money with these statins. And is this worth it? And I said, well, I think it's going to reduce the cardiovascular disease by 30%, but it's going to take 10 years. And it took 10 years, and it did exactly what I said. And then it continued to decrease as we also took care of the other risk factors and generalized it to the whole population, including the stroke patients, the diabetics, the chronic kidney disease. So I actually think that if we can just take what we already know and implement it, yeah, you're going to reduce cardiovascular disease another 30%, another 40%. And I would say 30% every 10 years. I think what happens right now is that we actually don't take what we know and fully implement it. So what Face on a Page also does is it's just not on a page. At Kaiser Permanente, they have a whole computer system, which everyone is using pretty much, this Epic, but we integrated into Epic to make lists. So every primary care physician every week gets a list of all their patients. Every patient's assigned to a panel. And they get a list. Is this patient's LDL a goal? Is this patient's hemoglobin A1C a goal? Has this patient had their blood pressure checked? Is it a goal? And so the primary care physician gets a checklist. And then they just check what they want the medical assistant to do based on the phase on a page. And the medical assistant goes back and calls up Mr. Jones and says, okay, we need to add another blood pressure medicine and you need to have a lab test in a week. Or Miss Smith, you haven't taken your hemoglobin A1C, we need it. Or your hemoglobin A1C on 2000 of metformin is inadequate. Let's add an SGLT2 inhibitor. So if we can just take what we know and integrate it, we can get really far sooner.
So we have all been impressed that Kaiser is a very well-run organization. Have you been able to implement that same program at Stanford since you've been there?
Well, that's what I'm trying to help David Marin with, but it's very difficult because the first thing you have to do is get these patient lists. So yes, I've been there, it's coming on 3 years. And, you know, you have to realize that Kaiser, I did all that work over 25 years. It started step by step. So we are working on it at Stanford. I'm meeting with the Epic people next week about lipids. I mean, it's small step by step, but of course it's much more difficult because everyone has a different insurance. Everyone, you know, has a different primary care provider. They're not all integrated, but yes, I am trying.
Well, are there any other questions from those who are online? If not, I certainly want to thank Eleanor for giving us this comprehensive discussion today. I want to thank Oliver for standing in line and providing us with the best information that's available on the vaccination program, and certainly Richard for showing us the commitment that the state has in providing that, and the huge amount of resources, $20 billion that has been allocated in just California for the COVID response and the flexibility in achieving that. So we want to thank everyone for that. So we're delighted to have Eleanor help show us that she's been able to reduce it. I'd like to point out that the goal for right care is getting the risk to zero. So we still have a way to go. I'm impressed that she was able to get it, the risk of cardiovascular disease under the risk of cancer. And so we are certainly passionate about further pushing that down. And I like your idea of if we can, our goal is 30% reduction every decade, then that gives us a chance to get pretty close to that. So thank you very much for all of our speakers. And hopefully all of you are surviving the current surge in the pandemic. We'll get through this. The light at the end of the tunnel, as Oliver pointed out, is going to be the vaccination program. We're a ways from it, and we've got, I think, another tough month to go through before we start seeing a downturn in that. But as more people get vaccinated, we'll get closer to that. So thank you everyone for that. I would like to point out for those attending that there is CME credit for this. And the CME survey that is required to do that is a short questionnaire that will then allow you to get credit for that. And I'll have Megan post online right now that link again to the for CME credit. So Jen or Megan, can you put on the screen the link for the CME credit? And with that, I'll turn it back to Hattie for our last comment.
I just wanted to say I'd love to have you all join us again in 2 weeks on January 26th, Tuesday, January 26th, from 4 to 6 p.m. We'll be hearing from Dr. Arthur Reingold. This was just confirmed over the weekend. He's a infectious disease specialist from UC Berkeley that's helping with the state and national scientific efforts on turning the tide on COVID-19. We'll also be hearing from our dear co-founder, Steve Shortell, on some health reform ideas that can help us do a better job going forward in the pandemic. We'll also hear from the Chief Quality Officer from Palo Alto Medical Foundation, Ed Yu, one of our co-chairs, who will talk about the struggles of how difficult it is to manage these things that we know are essential that Dr. Levin was just speaking about. I know Dr. Levin has a 2 o'clock appointment, so I'll just close by saying thank you so much, Dr. Levin, Dr. Brooks. Richard Figueroa is no longer with us. And just everybody take care, keep your guard up, and thank you so much for your dedication. So with that, please don't let up on your efforts, redouble them to protect yourselves, your families, your colleagues. And I hope by the time we meet again in 2 weeks, many of you will be vaccinated. And thank you for your work at the front lines.
Thank you.
Bye now.
Thank you.
Bye-bye.